Hello, Dr. Russ here. Today we're going to talk about the shoulder. If you are a provider or a student, a new provider, a seasoned provider, I welcome you. If you're none of those and you're just a human being with shoulders, I welcome you too. I hope that my experience can be helpful to you in figuring out what's wrong with your shoulder or figuring out what's wrong with your patient's shoulders, present or future patients. I know we all want to be able to move our arms. And I know that as providers, we want to be able to help people. And lots of people have shoulder problems. It's a very complex joint. It's under a lot of stress and strain, so it develops a lot of issues. I would like to approach this video without giving specific protocols that need to be memorized. Rather, let's review and get familiar with the anatomy. Let's talk about what processes and what kind of forces and strains are happening in the shoulder. Let's understand how our different modalities affect those processes, so then treatment decisions can flow from there. And we can do it in a principled way and in a way that doesn't require us to memorize a lot of protocols. I don't really like working that way. And I think a lot of people don't like working that way either. So, and you know, everyone's different. Every patient presents with a different set of issues and a different history, different types of treatment that they respond well to or tolerate. And so that's where protocols kind of break down. And that's where it's really helpful to be able to understand what's going on and recognize what you're feeling and be able to apply treatments to specific processes that are individual to that patient. So that's what I'm trying to do. That's the spirit of how I work, and that's the spirit of how I like to teach. So again, I'm Dr. David Russ. I'm a chiropractor. I'm in Portland, Oregon. I welcome you to this video. And if you like what you see and you would like to subscribe, that would be helpful to me. If you want to support our channel, there's a lot of ways you can do that. Subscribing, liking the video, drop a comment so there's some engagement. You can become a channel member where you would have early access to videos and badges and emojis and priority in comments. You can just give us a thanks. You can share this video as widely as you like. All of those things are really, really helpful to me, and I appreciate it, and it helps me keep doing what I'm doing. So with that in mind, let's talk about the shoulder anatomy and let's get into it. When people talk about their shoulder, they might mean anything from the base of their skull to their elbow. So what do we mean when we talk about the shoulder? Well, we talk about the 5 main joints of the shoulder and all of the muscles and fascia and neurovascular structures that go along with it. So there are 5 joints in the shoulder. The glenohumeral, that's the main ball and socket. The acromioclavicular or AC joint. The sternoclavicular or SC joint. The scapulothoracic joint, where the shoulder blade sits on the rib cage in the back. That's not a synovial joint, but it is a very important articulation between bony structures. And then there is the subacromial space, which is sort of quasi-synovial. It doesn't have a capsule of its own, but there are lots of synovial tissues in the subacromial space, particularly the sheath of the supraspinatus tendon, the sheath of the long head of the biceps tendon, and the subacromial bursa. And it's an area where people have a lot of problems for good reason. And hopefully I'll be able to elucidate some of that for you today. Here's a nice picture of the skeletal anatomy here. Here's that sternoclavicular joint right here, which interestingly is the only space in the body where the upper extremity has a bony articulation to the axial skeleton. It's connected to the neck through the upper trapezius and the levator scapula muscle. It's connected to the thoracic spine through the rhomboids and the serratus. But this is the only place where it really hooks in. And so all upper extremity movement goes through this spot. And I ask you, if you're a provider or a student, how many people do you know really work this space? So just knowing that it's there and it's important and how to work it, you're going to be able to help a lot of people that other people won't be able to help. And even though this is a clinical video about the human side of our desire to help our fellow humans, there's also the business side. And if you're good at something that other people aren't good at, that helps your business. Here's a side view of the shoulder. we can see the glenoid fossa. That's the socket of the ball and socket. With its labrum here, that's the cartilaginous ring around the socket, because that socket's pretty shallow. So like the hip socket is super deep and the ball sits way the heck in there. Well, the shoulder socket is pretty shallow and the ball just kind of like dangles. And so that labrum is this lip around the fossa, which makes it a little deeper, but still allows for lots and lots of movement. And that labrum is cartilage, and sometimes it tears. I also like this picture because you got the acromion process here, and then the coracoacromial ligament. So it really represents that coracoacromial arch. That ligament is not soft, right? And so it really doesn't allow for much movement. This subacromial space right here is small and tight and very limited in how much distension or swelling it will allow in the bursa or those synovial tissues before they start to complain and have pain. It can be very, very painful. Here's a nice coronal section of that. I like that you can see the sheath of the long head of the biceps here, and that subacromial bursa here, and that supraspinatus tendon here. And I think that's probably a pretty accurate representation of how crowded it is in there. It's important. Here's this nice view of that big fan, just that big fan, that deltopectoral muscle, really the main part of the lateral and anterior myofascia of the shoulder. Big, strong muscles, lots of movement, really, really important. But if we go underneath there and we look at these muscles, often forgotten, and a lot of therapists don't really know like how to get in there, especially on female patients. It's really helpful to be able to get in there. The pec minor, the coracobrachialis, and the short head of the biceps, all inserting on the coracoid process, all exerting anterior and inferior force on that coracoid process. So issues that shorten and tighten those three muscles create a protraction of the scapula, clamping down a little bit, making that subacromial space a little bit smaller, and restricting the movement of the scapula, which then in turn restricts and causes compensation throughout the whole shoulder complex. So these muscles, extremely important. You can also see the serratus anterior here, kind of hugging those ribs, wrapping around the rib cage, coming from the anterior surface of the scapula. Again, tightness, restriction, adhesion in that muscle will lock that scapula down on the rib cage. Doesn't have to be 100% locked. Even if it loses 20, 30% of its mobility, it's going to have ripple effects through the whole upper body. I work the serratus anterior so much, and I've got lots of treatment videos. If you're new to my channel, watch them. You'll see me working this muscle all of the time. It's super duper important. Here's a nice view of some of the neurovascular structures that course through the shoulder. Of course, the brachial plexus that hooks with the subclavian artery and vein right here in the scalene triangle, goes underneath the clavicle, underneath the pec minor, and out through the axilla. And I kind of crudely drew in the pec minor muscle here so you can see the relationship there. Lots and lots of upper extremity neurological entrapment issues originate right here under the pec minor and right here under the clavicle, as well as, of course, in the scalene triangle right here, because that brachial plexus comes out between the anterior scalene and the middle scalene. Of course, shortness, restriction, adhesion, trigger points, any issue with those muscles can create a physical entrapment, physical compression of that brachial plexus, which is then going to refer neurological pain into the shoulder, into the arm. And we need to know about that if we're treating necks, shoulders, and arms. Here's another view that I really like, showing this subclavius muscle here, hugging the underside of the clavicle. Again, a muscle not a lot of people know about. They kind of learned it in anatomy. Maybe they didn't, and they forgot about it because you can't see it, but it's there, and it's really important. It depresses the clavicle. It pulls it down. So here we are with our brachial plexus and subclavian artery and vein coming underneath the clavicle. If there's a tight, short, spastic muscle, hypertonic muscle there that's depressing that clavicle, it can have a tethering effect and literally compress that neurovascular sleeve, causing all sorts of issues in the upper extremity. This would be a good time to say, it's true that the body will prioritize protecting nerve tissue over muscle or joint tissue. So if there's some loss of space under the pec minor, under the clavicle, that is creating compression of the neurovascular bundle, your body will change its posture, even just subtly, to make space for it. And, here I am like side bending to my left to make a little slack in my left subclavian artery and neurovascular bundle. But now my right QL is stretching, and I've kind of created a little bit of a scoliosis in my spine in order to do that. So sometimes issues here will have far-reaching effects on the other side of the body, in the lower body. You never know. So it's good to be able to assess this area and treat it. That's what I'm trying to say. Here's a nice view of our sits muscles: supraspinatus, infraspinatus, teres minor, subscapularis, and of course, teres major. And it's nice to know a little more of the anatomy here in this space between the teres major, teres minor, the long head of the triceps, and the humerus. That's where the axillary nerve comes out, and it wraps around the humerus and innervates the deltoid region. So sometimes pain in the deltoid region is axillary nerve pain, where it's being trapped back here in that quadrangular space, as it's known. Similarly, just a little bit inferior to that quadrangular space, there's a triangular interval, technically not the triangular space, although it is a triangular space. Thanks, anatomists. Truly, we appreciate your work. And through there, between the lateral and long head of the triceps and underneath or distal to the teres major, is the radial nerve. It comes out there. Now, that radial nerve innervates the dorsum and the radial side of the forearm and the dorsum of the hand. So sometimes there's neurological pain. That's like that hot spreading pain, tingling, or even loss of sensation in the posterior forearm, the radial side of the forearm, and the dorsum of the hand. That can be traced back to here. So we work a lot on the triceps in my clinic. Again, another muscle people don't like to work or forget to work. It's really super important because of its relationship to those two nerves and because of its relationship to the latissimus dorsi, which is kind of the granddaddy of all of the shoulder muscles. And here it is. It's giant, right? It starts all the way the heck down on the sacrum and the ilium, the thoracolumbar fascia, and it comes and it twists, does this little dipsy-do through the axilla, and this whole giant sheath of muscle, like on me, would be inserting about, right? So there's a lot of strain on that point right there. And when the lat is tight, it's going to pull you into protraction, internal rotation, yanking on your neck, creating that upper cross posture. We'll put a link to upper cross posture in the video description. If you don't know about it, it's something you might want to look into, because if you're dealing with shoulder problems, you probably have some degree of upper cross posture. And if you deal with patients who have shoulder problems, you know they're going to have upper cross issues. And over here on the right side of the diagram, we can see the rhomboid major and minor, scapula kind of hanging from those, and the major scapular stabilizers of the middle trapezius and the lower trapezius over here on the left side. Not big movers, but very, very important stabilizers. And speaking of the rhomboids, we have our dorsal scapular nerve that runs deep to the rhomboid and superficial to the erector spinae muscle and can be entrapped in there. That can create hot pain and really kind of a horrible aching pain, almost like the knife in the back pain in the middle back between the thoracic spine and the scapula. Kind of feels like a rib out, but it's not. And if you do a lot of rib moves and you're trying to get a rib to release under there and you got your contact right on that dorsal scapular nerve and you're putting force through it and the ribs aren't going, you're just making the problem worse. So if you try one or two adjustments, if that's in your scope of practice and it doesn't go, then back off. Okay, say, you know what? I don't think this is the rib. Let's check your dorsal scapular nerve. And really what you're looking for is rhomboid adhesion and restriction or congestion in the rhomboid. And we'll talk a little more in this video later about what do I mean specifically when I talk about these different issues like restriction, adhesion, trigger point, and so forth. A couple of things to mention here. I work a lot with scoliosis. It's something I enjoy working with, and lots of people have it. It has a huge impact on shoulder function, mostly because of the change in shape of the rib cage that happens when the thoracic spine curves laterally. So in this diagram, this patient has a right thoracic convex scoliosis, and you can see the change in shape of the ribs, where the right ribs are going to kind of fold. That pushes that scapula, that right scapula, forward anteriorly into some protraction, and that can create issues over the long term, even if it's just a little bit. And so a big part of working with scoliosis patients is working with their shoulders, particularly the right shoulder, because that thoracic curve is almost always to the right for reasons we're not sure of, but is good because the heart's on the left. And if your thoracic curve is to the left, it's really going to interfere with your cardiac function. Here's a nice picture of a scoliosis patient from behind. You can see the asymmetry where her left scapula is nicely positioned and her right scapula is really quite protracted to the point where you really can't even see a shadow of the medial border there. So a big part of our treatment for this person would be obviously to the spine, try and make it as pliable and adaptable as possible, but also to train that shoulder to try to find a more comfortable position closer to neutral. And that would probably take some time, and that's okay. That's why we're here. So when we're working with any kind of a musculoskeletal issue, there's two things we need to figure out. And so again, we're talking about the shoulder today, but we could just be talking about the hip or the ankle. The processes are similar. The interventions are similar. We want to understand these things very well in general terms so then we can apply them to different regions of the body. And again, not have to memorize protocols for every single region of the body. So the things we need to figure out are what tissues are involved and what processes are taking place. What tissues are involved, what processes are taking place, what interventions do we have, and how do those interventions affect the tissues and affect the processes that are taking place. So that's what we're going to talk about for the rest of this video in relation to the shoulder. So what tissues do we have? We have myofascia, and I like the term myofascia because it reflects the fact that the connective tissues and the muscles are deeply intertwined, interrelated, can be teased apart with a scalpel, but are very much two sides of the same coin, myofascia. We have synovial tissue, which are the joints, but also things like bursa and tendon sheaths. We have cartilage, in this case, cervical discs, which can refer pain into the shoulder and certainly affect shoulder function. We also have, as mentioned before, the labrum in the glenoid. That's cartilaginous. And we just have the plain old hyaline articular cartilage in the sternoclavicular, acromioclavicular, and glenohumeral joints, all important. We've got nerves. Of course, we've got bones. We've got vascular tissue, arteries, veins, and lymphatic tissue. And then we have viscera. What processes can we talk about? Okay, let's get into some nitty-gritty here. This is the list of processes that I came up with. I don't think it's 100% comprehensive, but I think this really covers a lot of what we're dealing with. Inflammation. Let's go through these one by one. Inflammation. So that I know that you probably know what these are, but let's just make sure we're all on the same page about this. Okay. Inflammation is a local accumulation of fluid and cells in response to tissue disruption or the presence of a pathogen like an infectious agent or an allergen. Inflammation. It's swelling, it's immune cells, and the big part about inflammation when it comes to musculoskeletal stuff is the space that the fluid takes up. Particularly, imagine a bursitis, that little subacromial space. That bursa gets swollen, it starts pushing up against the acromion from the underside and down against the head of the humerus below, and it's distended and it's really irritated, and now it's also under pressure, and that's really going to hurt. A little clinical thought for you. When there is pain in the body, it is going to be partially mechanical from pressure, compression, overstretch, and it's going to be partly biochemical, from inflammatory mediators that are there that are irritating nerve endings. It's useful to be able to know whether a pain is chemical or mechanical. Usually it's a little bit of both. The extent to which the pain is present at rest is very much correlated to the extent to which that pain is chemically mediated. Okay? In the case of a swollen bursa, it's going to be swollen and hurt at rest, right? It's going to hurt more when you lift your arm because you're increasing the pressure inside that subacromial space, closing it down a little bit. So the degree to which it hurts at rest tells you how much swelling is in there. And it's really useful to know that, because when a tissue is swollen and irritated, you don't want to work on it directly. When a tissue is swollen and irritated, you want to do anti-inflammatory measures to calm it down, to help it feel better, so that it's not that tight water balloon. You don't want to jump on a tight, overfilled water balloon. You want to drain some of that water, and then we can start to induce some movement and some circulation in there. So, long story, inflammation. Next is tissue disruption, and that's tearing. And that can be micro tears or macro tears, but tearing of a tissue I call tissue disruption. It could be a strain, which is muscle or tendon, or it could be a sprain, which is ligament. Usually it's a little bit of both if there's an injury. It could be from an acute trauma, like a fall or a whiplash. It could be from repetitive microtrauma. That's why I just like to think of it all under one umbrella as tissue disruption, and it will cause inflammation, because that's tissue damage causes inflammatory cells to migrate. Then we have congestion. So we had inflammation, tissue disruption. Now we have congestion. Congestion is a local accumulation of lymph and venous blood due to impaired microcirculation through the area. And if you watch any of my treatment videos, and I hope you do, you see I talk a lot about congestion. Congestion is a sign of impaired circulation, which is a sign of deconditioning. And we'll talk about how that all kind of comes about a little bit later in the video. But you feel congestion when you're palpating. You get used to it. It's like palpation is a database of palpatory experiences that you accumulate in your mind, in your hands, over the course of your career, where you slowly learn what healthy tissue feels like versus congested tissue or disrupted tissue or acutely inflamed tissue. So it doesn't matter if you know how to recognize congestion now. What matters is that you learn. What matters is that you keep touching people and keep accumulating information in your palpatory data bank for you to compare to later. So 5 years from now, you is thanking you for palpating people now and just being curious and asking the question, what does this feel like? Because that's how you learn. So inflammation, tissue disruption, congestion, restriction is a very general term for anything that creates a loss of mobility between adjacent structures. It could be joint surfaces or myofascial planes. Restriction is just a descriptive term saying this doesn't move the way that it's supposed to move. It can be caused by congestion. It can be caused by adhesion. More about that in a little bit. Poor alignment of joint surfaces can cause restriction, or excess myofascial tension. So just as simple as a tight pec creating a restriction of shoulder extension and abduction, that's restriction, for example. Let's talk about adhesion. We talk about adhesion a lot in myofascial work. Adhesion is a loss of mobility, so it's a restriction between myofascial planes, but it's a specific type of restriction because it's caused by the consolidation of congested tissue into fibrous tissue. So we have congestion. Over time, if that congestion is not resolved, it will congeal, consolidate, and the body will convert it into a loose, irregular connective tissue, which is sticky, and it will prevent relative movement between these fascial planes. So this is our cycle. This is our unfortunate cycle of human bodies and just how mammalian tissue works. Restriction, loss of movement, creates congestion, loss of local circulation. Congestion will eventually consolidate into adhesion, which causes further restriction, which causes further congestion, which causes further adhesion, which causes further restriction. So this is why I have a job, because our bodies, when left to their own devices, will degenerate in this direction. So our job is to intervene in that cycle, which we can do quite well and quite easily and quite effectively, much to the delight of our patients and much to their tendency to tell their friends about how their shoulder like totally feels better. Okay, next process is a trigger point. So a trigger point is a very specific issue in the muscle, an irritable locus of muscle cells within myofascia caused by excess load on a muscle cell. So that excess load means it can't produce enough energy to keep up with what you're asking it to do, and that is sustained over time will create a trigger point. That can be either from you're asking it to do too much, or it's not getting enough arterial circulation. It's not getting enough fresh blood to keep up. Usually it's both. So yes, a trigger point can form in a muscle you never use simply because it's not getting enough blood supply. Okay, next, deconditioning. The loss of strength, elasticity, or pliability of a muscle or fascia due to disuse. The muscle's just out of shape. It doesn't just get weak. It also loses its elasticity. It loses its pliability. But good news is that it can be reconditioned if you intervene in time, and you do have years, right? The next step here in our processes is degeneration, and eventually deconditioning will lead to degeneration. It will lead to changes on the macro level to the architecture of the tissues, like osteophytes in joint degeneration. The bone looks different. It really looks different because it's been placed under stress for long enough that the body has had to create a significant response to those stressors. Osteophytes, for example. Degeneration is also the replacement of one type of tissue with another less functional. Really good example of this is scar tissue in a muscle. So if a muscle is torn and not appropriately rehabilitated and repaired, the torn tissue will be replaced, at least to some extent, by dense irregular connective tissue, a fibrous scar, which is important because it protects and stabilizes the area and allows you to have some function where otherwise there would be none. But it's not great because it's less functional than the original. So let's look back at our list of processes that we're looking at, so we don't want to get lost in the shuffle. Inflammation, tissue disruption, congestion, restriction, including adhesion, trigger points, deconditioning, degeneration. Now let's talk about referred pain. There's lots of referred pain going on the shoulder. This is one of the things that makes it hard to treat because the area of pain and the area of dysfunction and tissue irritation are not always the same. In fact, often they're not the same in the shoulder. So it's really good to be able to recognize referred pain and have references that you can go to, because referred pain patterns can be very predictable and consistent. For example, the teres minor and infraspinatus, even though they're in the back of the shoulder, will refer pain out here to the anterior and lateral deltoid. A lot of times those trigger points won't even hurt in the scapular area. They'll only hurt here. When you press on them, when you find them, and with your palpation, you will learn to recognize the palpatory feel of a trigger point, and you give it a gentle, slow, but direct compression, and it will often reproduce the patient's anterior shoulder pain. They're like, yeah, that's it. What else refers to the shoulder? The cervical spine, the facets, the discs, and the bones. Trigger points in the scalene, all the rotator cuff, the pectoralis, entrapment of the brachial plexus, whether in the scalene region, under the clavicle, under the pec minor, or in the axilla, will refer pain into the shoulder and upper arm. And then those subacromial tissues, often they hurt right there, but they will also refer pain, usually down, distal, down the humerus. There's three visceral structures that can refer pain in the shoulder. Very important to know what they are. One is, of course, the heart, tends to refer to the left side, shoulder and arm, also sometimes up into the neck and jaw. The gallbladder, tending to refer pain to the posterior, underneath the right scapula. And then, of course, the lung, which will usually refer pain to the ipsilateral, somewhere in the thoracic rib region or the shoulder, particularly the apex of the lung, can create pain in the shoulder. This is a diagram of what cervical disc pain looks like. It often does not involve neck pain. Sometimes it does, but a lot of times that pain will be perceived around the upper part of the scapula, really looking like a irritated levator scapula muscle or irritated rhomboid muscle. So it's important to know the signs of cervical disc herniation. Here's a nice picture of a cervical disc poking out and pressing that nerve root. You can see how that would send pain down into the shoulder and arm. But radiating pain, tingling, numbness, weakness in the arm, hand, or forearm. Worse with the Valsalva, that means worse with a strain. Also usually worse with a cough or sneeze. If you press gently but firmly on the top of the head, right, creating more compression through the cervical discs, and that increases their shoulder and arm pain. You're not changing anything else about their shoulder and arm. You just press here and they go, yeah, that hurts in my arm and shoulder. That's probably a cervical disc. You want to know about that. Usually their neck, even if there's not pain, it will be stiff and they will not want to move it. They can be really apprehensive about movement, even if the disc is not acute. These are the people who kind of walk in like this, and you ask them a question and you say, hey, can you look over here? And they're like this. There's different things that can do that. But when I see someone doing that, I'm thinking, I got to know if there's a cervical disc in there. So diagnosis is not in your scope of practice. I hope you have a relationship with someone who can do that and will do that for you and with you, referring for an MRI or whatever other diagnostic things need to be done. But generally, if there's no frank pathology, the answer to these issues is to restore mobility and circulation, because we have our unfortunate cycle of restriction, congestion, and adhesion, but we have our fortunate interventions. The intervention for restriction is mobilization. The intervention for congestion is to stimulate circulation, and for adhesion, it's reconditioning. So we are looking for mobility, circulation, and pliability. That's all, no matter what part of the body you're looking for: mobility, circulation, and pliability. Of course, with the caveat that there can be too much mobility, right? And in the shoulder, that happens, hypermobility, and that's a different video because that's a complicated thing to work with. So our goals are going to be to induce mobility, to stimulate circulation, and then to recondition the muscles, both manually with our hands to get in there and work out that scar tissue and break up those trigger points and dehes those adhesed structures and stretch and strengthen, which is often the patient's job in between sessions. We want to help them re-educate their posture, because a lot of shoulder and upper body stuff is just about this. It's just about their posture. They don't know how to get out of it. They're usually told to sit up straight, so then they crank down their thoracic and cervical erectors and have now added another layer of tension to the dysfunction, where the way out of the slump is actually to breathe into your sternum, lift and open your front ribs, and that allows your scapula more room to find a more peaceful and harmonious position on the rib cage, which then really frees up the neck to feel better. I've got a video, a short one, about the sternal lift breathing technique, which I will link to, and I hope that you use and share, because I think it would go a long way to changing the world. I really do believe that. And then a part of our job is to provide structure and guidance so the patient has a sustainable long-term plan to change whatever created this issue in the first place. And most people really want that. One exception to this is athletes who are going to keep doing what they're doing, even if it's hurting them. And I work with those people. As long as we both understand that that's what we're doing, then I'm good to do that. So let's talk about this process of intake and assessment. Now, if you are a massage therapist or other provider type that does not have license to diagnose, this part of the video is still for you. I believe that even if you don't have the legal authority to name it in Latin and put the number to it, you still are diagnosing on some level, because the patient comes in, your client comes in, and you're trying to figure out what's wrong so you can do the right thing. Well, that's diagnosis. So Stick with me and let's talk about it. Where do we start? Ask them what happened. Ask them where it hurts and what they can't do. With shoulders, a lot of times it's restriction of some movement. It doesn't go far enough, or it's weak, or anytime I reach, I get pain here, and find out what happened. Then, because you have a deep familiarity with the anatomy, and if you don't feel like you're there, that's remediable. Get out your anatomy book, watch some video, learn it. It's there. And the beautiful thing is that every patient who comes in has anatomy. And yes, of course, there's variation, but as mostly we're the same. And everyone who comes in is just going to lay on your table and, like you get to learn. So they're there for you in that way too. So let's say they say it hurts here. Well, you would ask yourself, well, what muscles are there and what do they do? There's the pec major, there's the pec minor, there's the subclavius, there's the upper trapezius, which has a clavicular attachment, super important. There's the sternocleidomastoid, there are the scalenes. Okay, well, what actions do they do? What actions do they antagonize? Patient says it hurts here and I can't lift my arm. That's different from a person who says it hurts here and I can't turn my head. This may be more of a scalene SCM trapezius issue, where this may be more of a pec major, pec minor issue, just to throw some examples out there. You also want to know what joints are there and how are they supposed to move. So armed with this information and knowing or having references for what pain referral patterns might be there, it's time for you to watch them move. And having someone do active range of motion is a wonderful way to sort of start your process of investigation. Once you've gotten the history and you're sure that this isn't an urgent care type of a situation, that the person who is sweating, having left shoulder pain, shortness of breath, and a crushing pain in their chest, is you're going to send them to the ER because they're having a heart attack. Whereas a person who has pain in the left shoulder, restriction of movement, no history of cardiovascular issues, is breathing just fine, is not in any apparent distress, you say, okay, well, let me just see you lift your arm up over your head. Let me see what you can do. And if they go like this, and they go and they're like full, like nice active range of motion, you can rest assured and breathe easy, like, okay, I think this person does not have a severe problem. And that's usually where I like to start. Just seeing what they can do tells me what I can do. Because if a person comes in and I say, can you lift your arm up over your head? And they're like, I am not going to take that arm and crank it over their head. I can see they're in a lot of pain. They're having a lot of restriction, and we're going to have to be gentle, incremental, and conservative in our approach. That's really, really helpful. Just ask them to move it and see what they can do. Then look at it, palpate it, and then do your passive range of motion. Passive range of motion is so incredibly useful. Palpation is so incredibly useful, assuming you know what muscles are there, what joints are there, how they're supposed to move, which if you don't know it now, you can accumulate that knowledge over time. It's okay. See if you can reproduce the pain. If you can reproduce the pain with a stretch, a compression, a range of motion, or isometric contraction, that goes a long way to telling you which tissue is problematic. If it's not telling you what exactly is wrong, what the process is, at least you can see, well, when I press on the pec major, it doesn't hurt. But when I get my thumb under there, and that's my middle finger under there, and squeeze the pec minor, that lights them up. Well, I think the pec minor might be involved. And that is really, really useful information to have. One other assessment modality or tool that's really useful is isometric contraction. So let's say we're going to do isometric contraction on the biceps. You put it in its advantageous position and you try and push while the patient resists. There's no movement going through the muscle or tendon. There's no movement in the fascia. There's no movement in the joint. This is a one position test. So really, theoretically, the only tissue that's being strained here and stressed is the muscle and the tendon. We know that's not 100% true, but it's kind of true, and we're going to use this. So here's my little table. I'm going to share with you one quadrant at a time. If your isometric muscle test is painful and weak, so they can't hold and it hurts to try, that's a moderate strain. That muscle is probably torn, not 100%, not full, but more than a little bit. If it is painful and strong, meaning they can hold, but it hurts to do so, that muscle is mildly injured, or perhaps there is tendonitis. If that muscle is painless and weak, in other words, they can't hold, but it doesn't hurt to try, that muscle is deconditioned, as we said before. It may be inhibited. The nervous system has just shut that muscle off, usually for postural reasons, or it may be denervated because of like a compressed nerve root from a cervical disc, in which case there would be all those other signs of cervical disc, or at least a few of them. And finally, your muscle can be painless and strong. Congratulations, that is a healthy, intact muscle. If it is a painless, strong test, but as soon as they let go, there's like a little flash of pain, that's consistent with tendonitis. I've seen that over the years many, many times. And of course, I didn't mention, what about a severe strain, like a complete rupture of the muscle? When that happens, and it does happen, there is a lot of swelling. There's usually bruising. The free ends of the muscle will usually bunch up like a window shade that snaps up because it's no longer connected. It just contracts back, and you'll see and feel the bunch. Usually, there's usually a lot of pain and like total loss of function. So I don't think that you would be fooled by someone who has a complete rupture of a muscle. Caveat of there is, if it's a muscle that has a lot of synergists, like the teres minor and the infraspinatus really help each other a lot. One of them could be completely torn, and still you would think that it's testing strong because they're able to push against you. So again, these things need to be correlated with each other. And as long as you're conservative and careful, you don't really need to worry about it. You just need to be aware of it. So let's go back to our basic principles. Be deeply familiar with anatomy, understand those dysfunctions and pathologies, understand how they present clinically, right? What does it look like when there's a tendonitis? What does it look like when there's a bursitis? And then understands how your interventions will affect these different pathologies and dysfunctions, because your treatment decisions will flow from there. And that doesn't change from patient to patient or from region to region. These are general principles that are useful and helpful no matter what part of the body you're working on. So beyond the scope of this video, we want to have approaches to mobilizing the joints of the cervical spine and the thoracic spine and the junction, which is probably one of the hardest places in the body to get to. The upper ribs, the clavicle at both ends, the scapula, and the humerus. We want to be able to mobilize, or if adjusting is in your scope, we want to be able to adjust those safely and effectively. And we want to have manual approaches to all of the muscles, not just the big ones. We want to be able to work the serratus, the triceps, the coracobrachialis, both heads of the biceps, that really important pec minor, that really important subclavius, those really important scalenes. And when it comes to working around the shoulder and your female patients, you want to be able to do draping so they feel safe and comfortable, but you can still access the structures that you need to access. And all that's beyond the scope of this video, but I try to demonstrate those in my treatment videos, which I do hope you watch or are watching. And as always, I really want and appreciate your comments on these talking head videos. Have you learned something? Were you surprised by something? Do you take issue with something that I'm saying? I would love to have that conversation with you in the comments. And again, I appreciate any support you can give. A like, a subscribe, a comment, a thanks, a membership. All of it is greatly appreciated. And I appreciate you watching today and sticking with me over 40 minutes. It's been a pleasure to talk about this, and I hope you have a great day today and tomorrow.